Thank you, Professor Choi and Professor Nomura. It's a great honor to be here. I greatly appreciate the opportunity to present our data before this society. Briefly, in the next 15 minutes, I'll try and describe results with liver transplantation alone for Hilar cholangiocarcinoma, our protocol with neoadjuvant therapy and transplantation, including the results, some of the special problems that we face in the care of these patients, and our recommendations and keys for success as we move forward. Well, as you all know, liver transplantation alone for cholangiocarcinoma is fraught with a high rate of local recurrence, a high rate of distant recurrence, and a very low survival rate. With approximately 20% survival at 5 years, one can simply not justify use of a deceased donor liver or a living donor liver for liver transplantation for this disease. Even for patients with early disease or incidental tumors that are not detected until the explant is removed, survival is equally poor. A U.S. SRTR registry study, a Canadian study, and a recent study from Cambridge in the UK all demonstrate a high rate of failure and recurrent disease after transplantation alone, even for early, previously undetected cholangiocarcinoma. With that in mind, in 1993, my colleagues and I at Mayo Clinic designed a protocol to treat patients with cholangiocarcinoma arising in the setting of primary sclerosing cholangitis. These patients, even with early-stage disease, are often unresectable due to the underlying liver disease, and our experience had been dismal with resection. We also wanted to treat patients with unresectable de novo cholangiocarcinoma. The protocol involves strict patient selection with predefined criteria, high-dose external beam radiotherapy, which is approximately 4,500 centigrade, along with 5-FU chemosensitization, high-dose brachytherapy with 2,000 centigrade, intraluminal treatment, abdominal expiration for staging prior to transplantation, and subsequent transplantation. The rationale for the protocol is as follows. With careful patient selection, we adhere to strict inclusion and exclusion criteria. They were specifically designed to identify those patients most likely to respond to neoadjuvant therapy and to survive after transplantation. Operative staging to avoid transplantation for patients that were destined to develop distant metastases. With radiotherapy and chemosensitization, we knew that a high-dose therapy was effective, but would be fraught with liver failure in several years after completion of therapy, and those problems are obviated by liver transplantation. With liver transplantation, we remove any residual disease. We almost always achieve an R0 resection because the hepatic margin is irrelevant. We also treat underlying PSC, and we avoid the liver failure that these patients were destined to develop due to their high-dose radiotherapy. The timing of the therapy and transplantation is equally important. We wanted to avoid dissemination during the operative staging and liver transplantation procedures, and thus administered all of the neoadjuvant therapy even before operative staging. The diagnosis of cholangiocarcinoma is based on a transluminal biopsy or brush cytology in approximately half our patients. The other half, as you know, it's very difficult to achieve a pathological diagnosis, and we've used a malignant appearing stricture on cholangiography and at least one of the following: a CA19-9 greater than 100, biliary ploidy by FISH, or a mass at the site of stricture on cross-sectional imaging. All of these patients were to have unresectable tumors grossly being located above the cystic duct, but we have had several patients with primary sclerosing cholangitis have microscopic involvement of the common bile duct when it's cut at the time of transplantation, and we've also treated potentially resectable disease in patients with underlying PSC. Naturally, these patients have to have an absence of intra and extrahepatic metastases and otherwise be a candidate for transplantation. Exclusion criteria involve intrahepatic cholangiocarcinoma, which we consider to be a different disease, uncontrolled infection, prior treatment with radiation therapy or chemotherapy, or a prior attempted resection or exploration for resection as it disseminates the tumor. Patients with intrahepatic metastases or evidence of extrahepatic disease are excluded, as are those with patients with a history of a prior malignancy. More recently, we've learned to identify and to avoid treatment for patients that have had a transperitoneal biopsy or fine needle aspiration of the primary tumor, including an endoscopic ultrasound-directed aspiration. And we've learned to avoid patients that have a radial tumor diameter greater than 3 centimeters. That's away from perpendicular to the bile duct, not along the bile duct. Our results since 1993 up until November of last year, we had treated 247 patients with neoadjuvant therapy. 26 patients died or had disease progression. 3 were transplanted elsewhere, and as of November, 6 were awaiting staging. 212 patients underwent operative staging, of which 44 had findings precluding subsequent transplantation, or 21% of the patients. 1's awaiting transplantation. 5 patients fell out while awaiting transplantation, and 3 were transplanted elsewhere. We performed 159 liver transplant procedures, 107 with deceased donor livers, 51 with living donor livers, and 1 with abdominal donor liver from a patient with familial amyloidosis. Of those 212 staging operations, 44, 21% had findings precluding transplantation. This was usually regional lymph node involvement or occasionally invasion of adjacent organs and tissues. We also had several patients with peritoneal metastases, including several that had had percutaneous aspirations or endoscopic aspirations, and we found seeds along the needle tracks. 38 of our patients, the 159 patients that underwent transplantation, had developed recurrent disease, which is usually local regional in the abdomen, but occasionally in the chest or in the bone. 1 was a tube site recurrence on a percutaneous tube, and 2 other patients fell out due to metastases at that site. The mean onset of recurrence is 27 months, or a median of 20 months, and it ranges from 3 months to 10 years. We've learned to identify predictors of failure. Predictors of dropping out on the protocol are a high CA19-9 at the time of diagnosis, a visible mass, and a high MELD score. Predictors of recurrent disease after transplantation include a persistent CA19-9 or a rising CA19-9 during neoadjuvant therapy, residual cancer in the explanted liver, and perineural invasion. Our overall survival for 247 patients that have undergone neoadjuvant therapy is 81, 58, and 51% at 1, 3, and 5 years after start of neoadjuvant therapy. The patients with underlying PSC do better than those that have de novo cholangiocarcinoma. The intent to survival analysis is 63% versus 35% 5-year survival from the start of neoadjuvant therapy. When we look at results after transplantation for the 159 patients, we have 91, 77, and 69% 1, 3, and 5-year survival. Again, it's better for the patients with underlying PSC at 81% at 5 years versus 52% at 5 years for those with de novo cholangiocarcinoma. Our experience has been corroborated by several other centers in the United States that have adopted our protocol, at least the major concepts of our protocol. We recently published a series of transplantation from 12 large volume U.S. centers. Intention to treat 5-year survival is almost identical to ours at 53%. And the inclusion of patients with out-of-criteria tumors, especially those greater than 3 centimeters, adversely affected results as it did with us. We do face a host of special problems with this treatment, including significant medical problems and neoadjuvant therapy problems prior to transplantation, hepatic decompensation during neoadjuvant therapy, common bile duct involvement, technical problems related to doing a complex operation in a highly irradiated field, and late vascular problems. With chemotherapy and radiation therapy, we have a whole host of problems, including potentially catastrophic gastroduodenal ulceration leading to bleeding and perforation. Almost all of these patients, or all of the patients, will develop cholangitis requiring hospitalization during treatment. The radiation therapy has a significant effect on the liver, as you can tell from the hilus of this explanted liver, and usually most of the tissue there is necrotic in the hilus, including the tumor by design. Common bile duct involvement we've seen in several patients with underlying PSC. The question was whether or not to do a pancreatoduodenectomy or re-excise the tumor. We've done both. With pancreatidodenectomy, this happened in 8 patients, and we've had 4 recurrences for 50%. For the 3 patients that we re-excised the bile duct and did not do a pancreatidodenectomy, the recurrences are 100%. However, it's a big operation in a radiated field. Here you can see the removed pancreatidodenectomy and the liver as well. And when one looks at our overall survival with 13 patients, because several of them were removed en bloc, knowing that there would likely be tumor present or from prior operations, you can see our survival after transplantation is significantly worse than transplantation alone. We also see a fair number of vascular problems, particularly portal vein stenosis, which we hardly ever see after deceased donor liver transplantation. And with the radiated native portal vein, we see a high degree of stenosis at 4 months on a CT, and we'll treat that by angioplasty and stent insertion. Fortunately, we haven't lost a graft, even though our incidence is approximately 20%. With living donor liver transplantation, we have a 20% complication rate with a native artery. We use the irradiated artery. With deceased donor transplantation, we avoid use of the irradiated artery and use an iliac graft instead. In conclusion, our recommendations for cholangiocarcinoma arising in the setting of PSC, neoadjuvant therapy and transplantation is the treatment of choice. For cholangiocarcinoma arising de novo, we still feel that resectable disease should be retreated with resection. Several of my colleagues have challenged that thought, and we're looking forward to a French study that's going to be a randomized prospective trial of transplantation versus resection for potentially resectable disease. But keep in mind, in our own experience, we have only treated those patients which we thought were unresectable. For those patients that are unresectable, they have little else to be treated with, and we've clearly established that neoadjuvant therapy and transplantation is effective for unresectable disease and essentially can achieve results either comparable or perhaps even better than those achieved with resection. When one's comparing the data with resection, keep in mind the number of patients that are operated on that are found to be unresectable, because it's the entire group that we have to compare survival for. So if one's looking at 50% survival, but only half of the patients were resectable, the overall survivability is only 25%. Our keys for success: strict adherence to the exclusion criteria are very important. The cholangiocarcinoma does need to be grossly above the cystic duct to avoid the inflammatory response to radiation therapy and the inability to clear the portal vein otherwise. There should be no other attempt at resection, and never perform a transperitoneal biopsy or fine needle aspiration of the primary tumor. Also, a patient that's too sick for neoadjuvant therapy is too sick for transplantation. Transplantation should not be done without completion of neoadjuvant therapy. From a realistic expectation standpoint, 10 to 15% of the patients will stage positive despite a negative endoscopic ultrasound prior to start of therapy. Most, if not all, of these patients will develop cholangitis, and the medical care of these patients prior to transplantation is quite significant. The transplant operations can be particularly difficult due to the irradiated field, and we do anticipate a 20 to 40% vascular complication rate and prepare to deal with those complications during the postoperative period. I'd like to acknowledge the large team at Mayo Clinic, former fellows, medical students, residents, and my colleagues in transplantation surgery and hepatology that helped in the design of this study, the acquisition of the data, and the analysis of the data. Thank you very much.